has enabled with an educational grant to make this possible. Today's talk is on influenza in pregnancy and the role of vaccination. And I think in today's day and age with COVID still such a major threat all over the world, this topic is extremely relevant and extremely pertinent. So I'm going to basically go through a little bit about influenza in pregnancy, of course, about prevention and the role of vaccination. And we are also going to touch a little bit about influenza vaccination in COVID times, as well as the co-administration of the vaccine with other vaccines during pregnancy. So if we look at influenza itself, I think this is our basic microbiology, but it's worth repeating because that's the basic understanding for the vaccination. It's a very highly contagious respiratory infection caused by the influenza virus. And there are three types, the A, B, and C. But most of the time we are dealing with A and B, which are responsible for clinical illness. Though in the past, A has got more of the limelight, influenza can occur with A and B virus strains. And influenza A basically has two subtypes called the hemagglutinin and the neuraminidase. And these are basically surface proteins. And based on which strain is more prevalent, you would get a various combination like H1N1, H3N2, which are the most common circulating strains. If we look at influenza B, there are two lineages, the Victoria line and the Yamagata line. And most of the time, one or the other would be responsible for the infection. Influenza C is rarely reported in humans and it's a subclinical infection. Now, just to understand that there is a certain convention in naming the vaccine or the virus structure from which the vaccine is derived. And as I said, the HA is the hemagglutinin and the NA is the neuraminidase. So if you look at this name of this particular strain, it would define the antigenic virus type, that is A, the place from where it originated, for example, Hong Kong, the strain number, the year of isolation, and what is the subtype, that is H and N subtypes. When we are looking at corona, and we have learned a lot of lessons from the corona pandemic, we know that in influenza, there are two main variations in the antigens, and one is the drift and the other is the antigenic shift. Now, if we look at the antigenic shift, because this is what we are all looking at in the corona pandemic as well, it's basically a reassortment between human and the avian strains, and it is only seen in type A. And basically what happens is two virus strains will infect the same cell and create a completely new virus, and this leads to a pandemic. Unfortunately, there's nothing we can do in pandemic situations as we are living through it right now. But where the antigenic drift is concerned, basically there are mutations in the hemagglutinin or the neuraminidase of the same virus. And this is what causes an epidemic. Very often I'm asked the question, why is India so concerned with influenza? Because influenza is a disease primarily of the temperate countries. But that's not true anymore. And especially because people travel all over the world, influenza is also seen in tropical regions as well as the temperate regions. In the northern hemisphere, typically the winter time, which is November to March, will be when we will see a peak in the influenza. And unfortunately, currently in the Western world, we are seeing the peak in COVID as well. And in the southern hemisphere, the winter, which is May to September, that's when the peak of influenza will be seen. In India, being in the tropical belt, we do sometimes see two peaks of influenza. In Maharashtra, especially in the coastal areas of Mumbai, we are seeing a pre-monsoon peak, whereas in North India, typically the peak is winter, that is December, January, February. I'm not really aware what is the peak season in Nagpur, but we have to understand that in India, we can have more than one peak where influenza is concerned. Another very common question that I'm asked is that how do we know which vaccine to give and which strain to give, etc., etc. So understand that influenza vaccine, a new strain, which is slightly different from the previous composition, is released by WHO twice a year. Initially, what happens is that there is a global surveillance system and data from more than 111 countries is collated. WHO then identifies the antigenic variants which are commonest in the influenza which was prevalent in the community. And then WHO decides which will be the most likely strain to be prevalent in the next season. And then it distributes this virus material to all the manufacturers. And this process then takes almost 6 months to produce the vaccine. So typically in India, if we have the Northern Hemisphere vaccine available, this vaccine is available around September to deal with the Northern Hemisphere peak, which is November to February. And if we are, say, in the month of April, then we would get the vaccine, which is the Southern Hemisphere one, which is released in April. Do not get confused about Northern Hemisphere, Southern Hemisphere, which one to give and which one not to give, because where influenza is concerned, every pharmacy and every stockist in the country at any given time will have only Northern or Southern. So whichever is the most recent strain that is released, that is the one that you should be using for your patient. I think this is a very important slide because today the slightest cough or the slightest fever and we all assume that it is COVID. Of course, we should have an extremely high index of suspicion where COVID is concerned for our pregnant women. And I don't know how bad the situation is in Nagpur, but in Mumbai now the COVID situation is slightly settling. But I have so many pregnant women who are asymptomatic and COVID positive. On the other hand, we also see a lot of the cough and upper respiratory tract infections, which we should be clear and we should be able to differentiate from influenza. So we should make sure that if there is high fever, headache, body ache, fatigue, extreme exhaustion, and cough and aches and pains, we should always think about a contagious illness like influenza. On the other hand, a common cold is usually self-limiting and sneezing is the main feature because it's more of a rhinitis. Whereas in influenza as well as COVID, sneezing is not the main symptom that is seen. Of course, COVID is defined classically by the shortness of breath and extreme exhaustion and headache, which is extremely common. So keep in mind that if you have a patient who has mild symptoms, you can give her symptomatic treatment for a day or two. The moment the symptoms have not resolved within 48 hours, please go ahead and think about a serious respiratory infection. Now coming to influenza in pregnancy itself. We know that the incidence of influenza in pregnancy is almost the same as the incidence in non-pregnant patients. But the point is that influenza in pregnancy is related to an extremely high maternal morbidity and mortality, along with a very high neonatal morbidity and mortality. This is more so if the pregnant mother contracts influenza in the second and the third trimester of pregnancy, where she's at risk for hospitalization, and then severe comorbidities can add to her complications. Most of the women with influenza in pregnancy who do have a mortality will have a mortality because of pneumonia or ARDS and multi-organ failure. Similarly, where the fetus is concerned, there is a 2 times higher risk for low birth weight and more than a 4 times higher risk of fetal death and preterm births. In fact, during the 2015 pandemic, when we analyzed data from KEM Hospital, we found that there was an overall perinatal mortality of 33%, which is fairly high. And a lot of literature from India, but unfortunately, many of the studies are small and not well designed. So here I just put together the data which basically shows that there is a high burden of both maternal and fetal complications in pregnancy, which could be maternal mortality, fetal loss, preterm delivery, ICU, prolonged hospitalization, and complications and ventilation. So obviously, I think the chairperson for the session said very clearly that just one small vaccine can prevent all this. And I don't think that I need to actually justify the need for vaccination, but we'll go through some of the fine tuning about the vaccine and the administration, etc. Obviously, prevention is better than cure. And CDC has said that an influenza vaccine is the best protection against influenza in pregnancy. So here the point when we are counseling our mothers is that we are giving her a double protection. So protection to the mother, because the vaccine will generate a robust response. It will prevent the complications. And most importantly, if she does get influenza in the second or the third trimester, despite vaccination, her need for hospitalization and adverse pregnancy outcomes are definitely reduced. The most important benefit to the newborn is the transplacental antibody transfer. And this is important because newborn immunization for influenza does not begin till 6 months of life. And in those 6 months, the child is vulnerable, and it is only the maternal antibodies which will protect the infant from influenza. Also, mothers who have been vaccinated, their babies have been found to have a better outcome in terms of birth weight as compared to those mothers who did not receive influenza vaccine during pandemic situations. Now, coming to the actual types of vaccines, we know that there is a live attenuated vaccine, which is an intranasal vaccine, which is contraindicated in pregnancy, like all live vaccines. The inactive vaccine is the one that is recommended in pregnancy, and we previously had only the trivalent available, and now we have the quadrivalent vaccine available as well. Now, the trivalent vaccine has 2 strains of A, that is H1N1 and H3N2, and the quadrivalent also has the same. The difference lies in the B strain. So in the trivalent, they either select the Victoria strain or the Yamagata strain, whereas in the quadrivalent, both the Victoria as well as the Yamagata are present. Now, this is important because in many cases, there is a mismatch in the B strain. What does this mean? That if you recollect, I said that WHO recommends the composition of the influenza vaccine for the next season. So WHO basically has to predict whether it will be Yamagata or whether it will be Victoria strain. And sometimes WHO can get it wrong. And sometimes basically the circulating lineage in the population does not match the vaccine lineage. And this is why sometimes the efficacy of the vaccine goes down. So also sometimes the predominant B lineage cannot be accurately predicted. And so if there is a Yamagata strain which is prevalent in the community, but the vaccine has the Victoria, obviously it will not be that effective. This is 2020 WHO data from the global surveillance, which also, if you see the orange bars, where it looks at the number of specimens positive for influenza by subtype, these orange bars, which take up a large area, are those where the lineage of the bee could not be ascertained accurately. That means it could either be Victoria or Yamagata, but they were not able to actually decide which one it was, because there is co-circulation of both lineages. Similar data from India also shows that irrespective of the geography, Delhi, Chennai, Calcutta, Pune, Nagpur, wherever, irrespective of the geography, there is co-circulation of both the Victoria as well as the Yamagata strains. So basically what this means is that the influenza virus type and subtype differ across cities in India as well as over time in various years. And that's why rather than the trivalent, we should ideally be switching to a quadrivalent vaccine, because this will take care of the unpredictable B strain, not knowing whether it is Victoria or Yamagata. Also, though I said that the bulk of the diseases are influenza A, there is a large group of patients and seasons where B strains will contribute to the influenza-related deaths and morbidity. And obviously the quadrivalent vaccines, which protect against both Victoria and Yamagata, will give a broader protection against influenza in general. Now looking at some important recommendations, and I always like to start by saying that WHO way back in 2012 said that in vaccinating pregnant women was one of the most important and cost-effective strategies, because pregnant women are an extremely vulnerable group. And WHO has said that any stage of pregnancy, irrespective of the trimester, the influenza vaccine should be given because it is safe as well as effective. ACOG has had almost 3 guidances to date, 2014, 2017, and the most recent, that is 2019, where they have said that all women who are or might be pregnant or in the postpartum period should receive the vaccine, and any licensed, recommended, age-appropriate inactive vaccine can be given at any time of the pregnancy. Similarly, FOXI had its initial guidance in 2016 and again in 2018. But we have actually in the FOXI guidance said that all pregnant women from 26 weeks onwards. I think this is to get over the reluctance of practitioners to vaccinate earlier in the pregnancy. But FOXI has also clearly said that in case of a pandemic, the vaccine can be given earlier to protect the mother. IAP has also strongly recommended that the influenza vaccine to the mother can provide protection to the infant for the first 6 months of life. Whenever any vaccine talk comes on, there will always be someone who says, but is the vaccine safe and should we give it? And there are more than lakhs of pregnant women in Europe and Canada who have been vaccinated, including the Global Advisory Committee on Vaccine Safety. All agencies internationally say that the influenza vaccine has an excellent safety profile and should be strongly, strongly recommended. This map is just to show that more than 100 countries recommend influenza vaccine for pregnant women. Now, just a little bit before I come to my final few slides about vaccination in COVID times. And an important point to understand that vaccination is an essential service. You cannot allow vaccination programs to be put on the back burner in the presence of COVID or any other pandemic. And both ACOG as well as CDC strongly recommend that the immunization should continue during the COVID pandemic. And here's the important thing. When we are calling patients to our antenatal clinics, we are restricting the number of visits that they have now because of COVID. So instead of the 7, 8, or 10 visits, we are now brought down the number of visits to 4 or 5. When we have brought down the number of visits to 4 or 5, an important strategy to ensure that we do the vaccination is co-administration. That means that we can co-administer the influenza vaccine with either the TT or the TD or the Tdap vaccine. And this is an extremely important strategy to reduce the number of visits as well as to improve your vaccination coverage. Ideally, I like to give the influenza vaccine in the second trimester, and I like to give the Tdap or the Boostrix vaccine the moment the patient has crossed 27 weeks. So typically when the patient comes back to me with her anomaly scan around 20 weeks of gestation, I like to give the influenza vaccine. And then the next time I call her at about 28 weeks, I will give the Tdap vaccine. But in case she has missed out on the influenza vaccine earlier in pregnancy, I can co-administer both at the same sitting at 2 different sites, ideally, of course, in the deltoid on each arm. Both vaccines, influenza as well as Tdap, can also be administered in the postpartum period in case the patient has missed out on taking the vaccine during pregnancy. CDC has also said that COVID, there may be an increased risk for severe illness in pregnant women in COVID compared to non-pregnant women. We haven't really seen a lot of that from the studies coming out of India. Most pregnant women with COVID have a very mild and asymptomatic course. So this is the quadrivalent vaccine of GSK. the Fluarix Tetra, which is a world's first inactive quadrivalent vaccine, which has both H1N1, H3N2, as well as both the B strains, with more than 18 crore doses sold across the globe, recently launched in India. And as we already said, it can be used in all stages of pregnancy because it is inactive. It can also safely be given in the postpartum period as well as during lactation. And it's a single dose 0.5 ml for the intramuscular use in the deltoid or the thigh. I already mentioned about the co-administration with Tdap, and this is an important intervention that we can do, especially during the COVID times. So I'd like to summarize by saying that all pregnant women and newborns are at higher risk of complications due to influenza. All international as well as national agencies strongly recommend the vaccine for pregnant women. The safety profile is excellent, and Fluarix Tetra or the quadrivalent vaccine should be the first choice when you are deciding which vaccine to be given. Just a last word about the common side effects which are seen in most vaccines, which is injection site pain, fatigue, headache, and myalgia, which may be seen, but rare events are really extremely rare. I always like to end by using this quote that vaccines are always available to us. But if we do not get our patients to come to us to take the vaccines cannot save lives. Vaccination will save lives. So I thank you all, and I'm open to questions now. Thank you.
Thank you very much, madam, for your wonderful, wonderful presentation. And things are crystal clear. And you have rightly said that it gives a double protection to the mother as well as fetus, and it is very safe in a pregnancy. And we should always go for quadrivalent vaccine. Okay, and you can give it in second trimester onward, and you have to combine it with other vaccines.
That's right.
Thank you so much.
Yes. I think there is some question in the chat box, which I just looked at, that what about the booster, somebody has asked. So basically the influenza vaccine, though today we are talking about pregnancy, understand that healthcare workers are also at high risk for influenza. And so all healthcare workers should receive the influenza vaccine every year. So basically all of us should also be taking the influenza vaccine every year. We should also be giving it to our hospital staff, and we should also be giving it to our old parents who are over the age of 65, because these are the really vulnerable groups. And where pregnant women are concerned, she should have an influenza vaccine in every pregnancy because the strain differs. So there's nothing like a booster. So in the non-pregnant interval, if she's a low-risk patient, she does not require it. But in every pregnancy, she requires influenza vaccine as well as a Tdap vaccine in every pregnancy.
Yes. Ma'am, the next question is about the cost, difference of cost in the tri and a tetravalent vaccine.
Yeah, so currently there is some difference in the cost, and I'm not here to, promote the cost or how will it be cheaper or not. But all historical data where vaccine cost is concerned shows that the more doses you use, the cost is going to come down.
Right.
So
yes.
I can only say that the quadrivalent is superior to the trivalent. Most of the international data on influenza vaccine in pregnancy, of course, is on the trivalent, though ACIP has come up with its own recommendations in 2019 to say that the quadrivalent is as good or effective as the trivalent.
Right. And can you please repeat the schedule of vaccine once again?
Right. So, the schedule that I personally like to follow, and which I think is a very sensible schedule to follow, is that, in fact, even Government of India has said that we should be phasing out TT, tetanus toxoid, and we should be replacing tetanus toxoid with TD, that is tetanus with diphtheria.
Yes.
So big T, small d. So what I like to do is in the second trimester, maybe around, as I said, right now, because of the COVID, when the patient comes with the anomaly scan at 18, 19, 20 weeks, I give the first dose of TD along with influenza, because I don't want to miss out on the opportunity later. And when she comes back at 28 weeks, I give her the Boostrix or the Tdap.
Correct.
Now, if cost is an issue, of course, we can't argue which would you prefer if cost is an issue. But if you space out the two vaccines, then cost doesn't become that major an issue if you're giving influenza earlier and Tdap later. In case she really can't afford, then at least you should give influenza in the second trimester, and instead of TT, then give her TD at least, and don't give TT, because TT is nothing. I mean, people have now disregarded TT in most of the studies.
True, ma'am. Right. And if mother has, what about patients who have already recovered from COVID? Is it safe to give in such patients, the
Yes.
post-COVID
Yes.
recovery?
So it is safe to give, because you have to understand how the vaccine works. The influenza vaccine is not going to be affected by the COVID. Okay. It's just not
Correct.
going to be affected. So if you have to say that, should I give this vaccine or this vaccine, each vaccine will act against a particular disease. So you must continue once the patient has recovered from COVID.
Yeah. And there's one more question. If mother has already taken influenza vaccine, then also in pregnancy, we have to give it?
Yes, yes. So what the American recommendation says, that if she is likely to become pregnant, see, because over there it is very, very well defined and seasonal. So suppose in November a patient says, I'm planning a pregnancy. Okay, then they would say, take the flu shot so that you don't become infected or don't fall ill.
Well,
So
yeah.
if you're planning also, you can take, and then that validity is a year. But it is better to give once the first trimester is over. And a lot of studies have found that there is no difference in the protective antibodies to the neonate, whether you give it early in the pregnancy or late in the pregnancy. So you can take every opportunity basically to just not miss out on any patient and vaccinate.
Right, right. And which vaccinations for senior citizens?
So for senior citizens, definitely influenza vaccine. And I'm not a big fan of many other vaccines, though nowadays they say pneumococcal and this and that. There are so many vaccines available, but at least influenza for sure.
And which time of the year, ma'am?
So in Mumbai, typically I like to vaccinate for influenza in April, May, June, which is just prior to the flu.
Prior to monsoon, yeah.
Monsoon, you
Yes.
know, because we have so many monsoon related illnesses in Mumbai, especially with malaria, leptospirosis, dengue, etc., which are waterborne and monsoon related, along with Hep E, hepatitis A. So it's better to vaccinate pre-monsoon.
Yeah, so the AAP recommendations is 15, at least 15 days prior to onset of monsoon. So that's what, like you said. Delhi government hospitals have replaced TT with TD in pregnancy. That's what Dr. Neeta Sapre ma'am has
That's
commented.
exactly what I said, that
Yeah.
there is a 2018 recommendation from the Ministry of Health, which says replace in a phased out manner all over the country TT with TD.
Yes. And this is a question from Dr. Pushpa Jungare ma'am from Amravati, my teacher too. She's asking you, as are the vaccines given free of cost in government hospitals?
If only. So I'll just give you a small story for this. In 2015, we had a really bad sort of pandemic of influenza in many parts of the country. At that time, we lost quite a few mothers to influenza in the tertiary care centers. And so the BMC, the Bombay Municipal Corporation, bought 1 lakh doses of influenza vaccine, which they circulated to all the BMC hospitals in Mumbai, to give it to the mothers in the third trimester, because those 1 lakh doses were not going to last. So that is the only time they gave the vaccine free. But that was a knee-jerk reaction. There was an influenza epidemic, mothers died. So what do? Give the vaccine. I wish that more people would understand that vaccine programs deserve money to be spent on them.
True, ma'am. Well said. Yeah. The next question is, ma'am, when the patient gets registered in a PHC, 2 doses of TD are completed by 12 weeks only. Will that suffice or is a third dose necessary?
So the 2 doses of TT which are given at any stage of the pregnancy, and that's actually the WHO recommendation. If you don't know her status, you can give tetanus as early as the registration. But the difference is that Tdap is going to protect against pertussis. And let us not forget that India is one of the leading countries for pertussis related morbidity and mortality, especially in the infants who are less than 2 and 3 months old. So our infant schedule begins at 6 weeks of age. And if we don't vaccinate for Tdap in the 3rd trimester, then we are going to have many more pertussis related deaths. So even if she has finished the TT, okay, I don't think we have seen neonatal or maternal tetanus for donkey's years now, because we are free of that. So better to give the Tdap, which will protect against pertussis as well as diphtheria.
Yeah. And now one more important question, ma'am. New strains are out around October and November. Still, do you want to give it in April?
No. So
are they out in October? No, they are.
What happens is that they are released in February and September. February and August. By the time they hit the market, by the time they hit the domestic market, it may be October. But I would not wait for the next strain to come. I would certainly not wait for the next strain to come, because I will lose the patient. How many of us have told the patient we'll do this next time and the patient doesn't come back? So I would not look at the seasonal peak. Rather, I would look at the gestational age and just vaccinate.
Right, right, ma'am. I think most of the questions are covered. Over to you, Rajesh.
Yeah. Thank you very much, madam.
Thank you.
Now we move on to the next topic.
Rajesh, before that, okay, I just thought you're making sense. Ma'am, your student is here, Dr. Meghna Agrawal.
I can see my 2 students, Bhakti Gurjar as well as Meghna.
Where's Bhakti?
Bhakti is there. I can see her.
Meghna, Meghna.
Yeah, hello, ma'am.
Hi. So
How are
I
you?
was in fact about to log out, but I said before I log out, I have to say a big hi to Meghna and Bhakti and
Thank you, ma'am.
Nagpur Society. And as I told Vaidahi, you are going to have a little overdose of me on the following weekend. That workshop,
but that's not going to be an overdose at all. We just love to have you all the time. That's Bhakti.
Different.
Hi, ma'am.
Hi. Who's saying hi now?
Bhakti.
Bhakti here, ma'am.
Hi. So thank you very much. And if you'll excuse me, I'll have to log out. Yeah.
I know, ma'am. Thank you so much, ma'am. Rajesh, before we start the next session, I invite the executive from GSK, Mr. Bhoyer. Mr. Bhoyer? Wait, I think I need to unmute him. Mr. Bhoyer, you can unmute just for his remarks. Yes, go ahead, Mr. Bhoyer.
So once again, doctor, thank you so much as a Foxy president, Dr. Vaidehi Marathe, and NOGS always. And
not
NOGS
Foxy,
always,
NOGS president.
Sorry, I'm sorry. So NOGS always backed GSK, my Boostrix and all. So first of all, doctor, last time also you have given me a platform, NOGS platform, to launch our Boostrix, and now the fact is that Boostrix is the protocol. Boostrix is that the protocol of 90% obstetricians in Nagpur, and that is really a good thing. That is really good thing. And now, doctor, I thank you, Dr. ANAHITA Chauhan, to have Fluorix Tetra presentation over here. And I'm sure, I'm 100% sure, doctor, most of the 90 to 100% gynecologists or obstetricians are going to make mandatory flu vaccination in their protocol as a flu vaccination. Yeah. So I thank you so much for your very nice presentation, ma'am.
I just want to add one thing, because somebody asked a question about cost.
Yes.
It doesn't matter, according to me, which vaccine you give, as long as you give a vaccine.
Correct.
Okay? Yes. So today we are talking about GSK's Fluorix. That it's not necessary that you have to, because the more vaccines you use, the overall cost will come down. So the first idea is promote vaccination and talk about vaccination at every opportunity with your patients. then the choice of brand, of course, is yours. I don't mean to pull away from GSK's brand, but I'm just saying that first get into the mindset of prescribing vaccine. So the first step is make sure all your pregnant women get Boostrix and get an influenza vaccine.
Yeah. Thank you, ma'am. For the pricing and all that, I am here to pass the communication. Don't worry about that. As a GSK representative, so Fluorix Tetra, doctor, is all of you know it's the world's first approved quadrivalent vaccine, and it's the only vaccine which has got the Indian efficacy data. This is very important one. Now coming to the price, because many of doctors have asked that the MRP of this vaccine is 1800 rupees. That is 1800. And the hospital price that we are supplying to the doctors is just 1000 rupees, and that includes the cost also, this GST also. So we have kept that 800 rupees, the difference between the price and the hospital price and MRP of the vaccine. So, but as the Dr. ANAHITA has mentioned, that flu vaccination is very important and it has to be given to every single pregnant woman. That is the take home message. I'm sure, doctor, most of them have already taken that. So I thank you, Dr. Vaidehi Marathe, to give this platform to GSK to again have our Fluorix Tetra in platform. And I request all of the obstetricians present in this program to use Fluorix Tetra as a flu vaccination in the pregnant women. Thank you, Dr. Vaidehi Marathe. Thank you so much.
Mr. Moore. Thanks for